I'm Amber Tresca, and this is About IBD, the podcast that knows that you can have IBD and IBS at the same time. I'm a medical writer and patient educator who lives with a J-pouch due to ulcerative colitis. It's my mission to educate people living with Crohn's disease and ulcerative colitis about their disease and to bring awareness to the patient journey. Welcome to episode 178. We know that people with IBD tend to have more challenges with their mental health. Yet it is still not common to be referred to a mental health professional. On top of just getting started with finding a therapist, there's the cost to consider. Whether or not therapy is covered by insurance is all over the map, which puts it into the nice to have bucket when it should be one of the essentials for managing IBD. My guest is Dr. Ali Navidi. Dr. Navidi is a gastropsychologist, which means he specializes in helping people with digestive disorders with their mental health. Dr. Navidi sets the record straight on cognitive behavioral therapy and clinical hypnosis. In particular, he explains why you may have tried CBT in the past and found it didn't work, and how clinical hypnosis has a bad reputation when it is actually a useful tool for people living with chronic illness. Dr. Navidi is a licensed clinical psychologist and the co-founder and CEO of GI Psychology, a national telehealth practice that treats patients with gastrointestinal disorders. He understands a broad range of GI conditions and is trained in clinical hypnosis and cognitive behavioral therapy. Dr. Navidi, welcome to About IBD.
Amber, thank you for having me. I'm happy to be here and happy to have this conversation.
Me too. I have really been looking forward to this. My first question, though, I just want to know a little bit more about you. Would you tell us what brought you to psychology, and then what inspired you to specialize in GI health?
Yeah, psychology, that was an interesting road, and it basically was driven by hypnosis. I think it was maybe in my 20s, I found this book on hypnosis. It was like this old school little black book and a very old style. And if you don't know anything about hypnosis, it's really the style of using it has changed a lot over the years, but that's a whole different conversation. Mm-hmm. So anyway, I found this book and it was a family vacation, and just for fun, I went and used the book to hypnotize my sisters and cousins and
stop it.
And it worked on some of them. It didn't. My aunt was great. Like, she was awesome with it. But that's how it kind of started. And I just kind of had an interest in hypnosis and psychology since then. And I wasn't very good at choosing professions, so I actually got a degree in microbiology. Oh. and started working in biotech. Mm-hmm. And was about to get my degree and about to start a degree in doctorate in biochemistry. Mm-hmm. And then I finally saw the light and shifted gears.
You know, sometimes I'm a little on the fence about asking people why they got into their profession, because sometimes the answer is really not terribly interesting. I am super glad that I asked you that question.
Yes.
So this is a little bit of an aside, but I can't let this go by. So how did you talk people into letting you hypnotize them? That seems like a really high level of trust that you must have had with your siblings and your family members.
This is all siblings, this is all family, and it's fun. Like, people are fascinated by hypnosis. Mm-hmm. There's this love-hate relationship that we have as a culture have towards hypnosis. Mm-hmm. You know, on the one hand, we think of it as this the devil's tool, and it's like mind control and evil magic. And on the other hand, it's this amazing thing that can magically let you know more about yourself. And so we have all these cultural beliefs about hypnosis that I think for kids and teenagers at the time mm-hmm. It's almost irresistible, mm-hmm. right? Yeah.
That makes sense. It's like candy. Let's see what we can do here, you know?
Yeah. Yeah. And I'd love maybe later I can speak about what it actually is versus, everything that the movies and, stage magic have shown us, right?
Yes, 100%. We absolutely need to get to that topic. My first topic, though, is to talk about stigma, much less entertaining than the story of how you came to be interested in hypnosis. But, we hear a lot in the chronic illness community that we're told that our symptoms are all in our head,
Yeah.
and it's uncomfortable to talk about digestive problems in the first place. So these two things together, people might wind up just keeping their feelings about having IBS or having IBD to themselves.
Yeah.
So I'm wondering if you have any thoughts, and I'm sure that you do, about how we can help people overcome these ideas and to better address their mental health when it comes to GI disorders.
Yeah. So my view of stigma is that it's always best to start within and then kind of move outwards.
Oh.
Right. Mm-hmm. So, obviously it's hard to fix everyone else's opinions, especially until you fix your own. Right. So if the person, and by the way, it's all in your head is like this huge pet peeve of mine. 'Cause if you just think about the statement, it doesn't make any sense. Mm-hmm. How could it be all in your head if it's also in your gut? Mm-hmm. If it's also in your nervous system, if it's, you know what I mean?
Yeah.
It can't be all in your head because the symptoms are real, right? Like things are happening in the body. So regardless of whether you're talking about IBD, which is a disorder of the immune system, or you're talking about IBS, which is a disorder of the nervous system, right? It can't be all in somebody's head, or we wouldn't even be talking. It wouldn't be a problem. The fact that it's in our body and our body is connected to our head, now that's a different story because of course the body's connected to the head. So of course what happens in our head affects our body, and what happens in our body affects our head. That's obvious because we have a neck,
Most of us.
Most of us have necks. So, of course, there's mind-body interaction. It would be very weird if there wasn't.
Yeah.
Yeah. So I think that's the first step. Is like, let's throw out this it's all in your head kind of talk because it obscures a lot of the subtleties and nuances about these different disorders. Yeah, I think that's the first step is like realize, okay, that is a ridiculous statement and that these are profoundly difficult disorders to live with, no matter the severity, just as difficult as any not in your head disorder. I can't even say that phrase without getting worked up. But yeah, these are very difficult disorders to deal with, and that should be appreciated right off the bat. And once you understand that it takes a lot of courage and a lot of hard work to deal with either of these problems, then you need to realize that, we don't live in isolation, and that however you can do it, it's best to have a group, a society, your friends, your family, as many allies, as many supporters as you can get. And maybe the first few getting them is going to be a little anxiety provoking, but it's definitely worth it. It's definitely worth it.
So as far as internalized stigma is concerned, I haven't really thought about it in that way, but that does make sense that you kind of have to get over your internalized stigma first.
Yeah.
Is there a roadmap for that? How can people start?
Well, I think the start, it should come with working with somebody, whether you're talking to someone else who has the disorder, whether you're in a support group, whether you're talking to a therapist or a GI psychologist, it's hard to see your own blind spots. It's hard to see where you might be too hard on yourself, or you might be looking at yourself from a distorted view, because when it comes to things that are very personal and very painful, that's where we tend to not see things so clearly. So when we're working on our own internalized stigma, it's good to have help, right? Because it's just hard to be objective when it's such an internal, difficult, painful thing that we're talking about.
Right. That makes a lot of sense. And in the past, IBS and some other conditions too were, I don't know, they were called all sorts of different things, diagnosis of exclusion, this type of thing. But now we're referring to them as disorders of gut-brain interaction. I think that's a new one on some folks. So I wonder if you would explain a little bit more about what that means.
Yeah. So in 2017, the Rome Foundation changed their designation. And these disorders used to be called functional disorders. Functional disorders is, in my opinion, kind of a lame name for a disorder because it just doesn't tell us anything. All it means is that your function is messed up in some way. It doesn't talk about why. It doesn't talk about the roots of it. It just says, oh, the function's messed up. And other than that, we don't really know much. It's kind of like they're giving up when you call something a functional disorder. Whereas DGBIs, disorders of gut-brain interaction, it's actually starting to give us something, right? It's pointing us in a direction. And it's saying, okay, we're not like just throwing up our hands and saying we don't know. We're saying, okay, the evidence is beginning to point to that this is an interaction between the gut, the enteric nervous system, and the central nervous system. And the way they're interacting is creating these negative feedback loops that are causing all kinds of problems for the gut. Okay, so now we have like a lot more information. So I actually like the title a lot because it starts to point us in the right direction and how we might improve things.
Dr. Navidi, people might not realize that you can have IBD and that you can also have IBS, which might explain to some people why they tend to get the IBD under control and their labs look good and all of that, but they're still having symptoms. Can you talk a little bit about how this crossover can impact people?
Yeah, I think you explained it really well. It can be very frustrating because you work hard to get your labs under control. You're trying to live a good lifestyle. You're taking your meds. You're doing everything right, and then the labs are good. You should be feeling good, and yet you don't.
Yeah.
Right. And so there's actually two problems occurring here. Right. There's IBD. The immune system is under control. That's good. And then there's IBS, or another one of the disorders of gut-brain interaction, because there's many different of these disorders. And so that's solved differently. The same medications that are helping your IBD aren't going to touch IBS.
Right.
Because it's a whole different issue. It's a problem with the nervous system. Needs a whole different kind of treatment, right? There was a patient I worked with, Zach, and he came to me when he was a teenager, and he had that exact situation, except it wasn't IBS. It was kind of a vomiting disorder. So whenever he wasn't on like high dose steroids, he was vomiting multiple times a day, even when his IBD was under control.
Right.
And they were considering doing various types of surgery, and luckily came in and we treated the disorder of gut-brain interaction, the vomiting problem. He responded really quickly. Hypnosis worked well for him. And it actually ended up being a story that was covered because Zach wanted to let people know about it. So he ended up talking to a reporter with The Atlantic. And so there's a story that got published a few years ago, which I was really glad that it did, because it talks about that issue, and it got the word out to more people. So the answer is they're two different things, need two different types of treatment, but it's very, very treatable. Oh, and I didn't mention, but the treatments out there for these DGBIs like IBS and other disorders, like they're very effective, like 80%. Like I think I mentioned that, but 80% will meet their treatment goals. So there's no need to just live with these problems because they're very treatable.
So when somebody comes to see you and say that they already know that they have IBD and then they also have, let's say, IBS.
Yeah.
Would the treatment focus on the two together, the two separately? Like, is there a distinction there?
Yeah. So you would do kind of a comprehensive intake. You'd want to understand what's happening. So maybe there'd be pain and discomfort from IBS. Maybe there's medical trauma from IBD. Maybe there's a history of anxiety or depression. You want to understand the bigger picture, and then you'd work with the person collaboratively to figure out, okay, like where do we want to start? What's going to give you the biggest bang for your buck? Is it if we go after the IBS first? Is it we deal with the anxiety, or maybe we want to deal with the trauma? Like we make a plan together after we've kind of gotten the big picture.
That makes sense. I am coming to believe that I think that everybody who has IBD has some kind of medical trauma, that you almost just can't get away from it.
Yeah. It's hard not to, especially if you combine trauma with stigma.
Yes.
And we know stigma is going to make the traumatic reaction worse. And so, it's hard to get away from it. You're right.
They're feeding off each other.
Yeah.
Up next, Dr. Navidi tells us why we have the wrong idea about clinical hypnosis. Dr. Navidi, let's talk more about clinical hypnosis. You already went through a couple of the misconceptions that people might have about it.
Right.
So can you tell us how hypnosis is actually used in people with GI disorders?
Yeah. So it's a tremendously powerful tool. It's got a lot of uses. So that's why I kind of get a little overwhelmed, because there's a lot of different things you can use it for. We can start with a very straightforward use, which is working with pain, right? So whether you're talking about IBD or you're talking about IBS, pain is often a component of these problems. And what I think most people don't realize is, and this maybe comes from the it's all in your head kind of thing. All pain is in your head. And what does that mean? That means that if we did not have a head, if we did not have a brain, nobody would have any pain, because the signals from our body are processed by our brain. There's no pain until the brain processes things.
Right.
And what that means is that treatments that can affect the brain can affect pain. And so there's a lot of different techniques using hypnosis that people can use to change the way they experience pain, to reduce pain, to change the way that they're emotionally reacting to the pain. There's this great researcher called Mark Jensen. His name's Mark Jensen, and he does a lot of interesting neuroscience and clinical hypnosis research. And he can show you the different parts of the brain where these different hypnotic suggestions are influencing, right? Like it gets that specific, like, okay, this suggestion to reduce the pain, this is showing up in this area, whereas the suggestion that the pain won't bother you as much, that's showing up in a different part of the brain, right? So all that to say that one of the great uses for clinical hypnosis is in helping people manage pain.
Interesting. Now, you said earlier that your first foray into hypnosis, you had some subjects who were more susceptible. Is that how you phrase it? And then others that maybe were less. How does that work? Would someone know
Yeah,
before they came to see you that this was going to be something that would work for them?
that's a great question because a lot of people have that as a concern.
Mm-hmm.
Now, and the term is susceptibility, and I don't like that term.
Yeah.
The term I prefer is hypnotic talent,
Nice.
right?
Mm-hmm.
Because I think if you're good at hypnosis, that's an amazing talent.
Mm-hmm.
That's something that, you owe it to yourself to develop because you can do a lot with it. You can use it to manage your anxiety. You can manage pain. You could help to change bad habits. Like it's a nice tool to have.
Mm-hmm.
So I see it as a real talent. So when they've studied this, they found that it's normally distributed in the population. So it's like, the bell curve,
Mm-hmm.
right? And so there are certain people who are just like phenoms. They're amazing. There's videos I could show you of them getting surgery with their eyes open, talking to their surgeon while they're cutting out, it's just amazing.
Wow. Yeah.
And then there's the other end, right? And there's the small group who's amazing, small group who's just like talking to a brick wall.
Mm-hmm.
They just cannot wrap their brain around the skills involved for using hypnosis. And so you have these extremes, but then most people are in the middle.
Mm-hmm.
And unless we're prepping you for surgery, you don't need to be amazing. We just need you to not be terrible. Right?
Yeah.
And most people are going to be average, and average is just fine to benefit, to reduce your pain,
Mm-hmm.
to use it for anxiety or something like that. Like average is going to be just fine.
So it sounds to me as though, because you're talking about it as a skill, that it is something that people can improve over time if they practice it. Does that sound right?
Yeah, absolutely. I can give you just a really simple example.
Mm-hmm.
Everybody's kind of heard of Pavlov, right? Like
Mm-hmm.
ring the bell and the dogs are drooling.
Yeah.
Well, there's similar concepts. We use that in psychology. And so when we use hypnosis, we create something called an anchor. So let's say I just did this today, actually. I was a really anxious young man, and I taught him how to use hypnosis to calm himself down,
Mm-hmm.
right? And it took about 10, 15 minutes, something like that. And he was feeling really relaxed at the end of it. But I don't want him to have to, come and find me every time he needs to
Yes.
calm himself down. I need him to learn to do it. So we created an anchor, and we picked like the left fist. So he makes a fist, and then it just automatically relaxes very deeply.
Mm-hmm.
So we created this conditioned response, and the more he uses it, the more automatic it's going to be, the more powerful it's going to be. Because one of the things they say in neuroscience is, I'm going to forget it. Neurons that fire together wire together.
Okay. Mm-hmm.
Right? That's pretty common. And so the idea is that we're pairing these two things over and over again.
Right.
Left fist, relaxation, left fist, relaxation. The more he does it, the better he gets at it, the more he can relax himself when he needs it.
So interesting. So it took 10 or 15 minutes. Is that common? Can it take longer? Is it, do people need to see you for a series to learn how to do that for themselves?
Yeah, that's another good question because to learn to go into trance for the first time, it could be as short as 10 minutes.
Wow.
You can take much longer and do a much more thorough, kind of like very relaxing type of trance. And that's in the session.
Okay.
But what the research has shown, like let's say if we're working with someone with stomach issues, they might start to get relief after, let's say 3 sessions.
Mm-hmm.
So maybe 3 weeks later, they're already starting to feel better.
Mm-hmm.
But what the research shows is that it's better for them to do the full 8 sessions
Okay.
because there's something about completing all those other sessions that just really burns it into the brain that makes it like a lasting change. And there's something about, 8 to 10 sessions. It's like this magic number that they've kind of gotten it. So if it's going to help them, often you're going to know it. So that's the other nice thing. It's a relatively short-term treatment too.
Right.
Yeah.
Yeah. I think from a lot of the research that I've read, it always does seem to be somewhere between 6 and 10 sessions that are tried for these before they look at outcomes. So that's so interesting. But it makes sense. You're building a new habit. You're not going to get it just from a 15-minute session. It's going to take a little longer. So that does make sense.
Right. It's like that 3-month mark, something around there,
Yeah. To build that habit and then to make it stick. Gosh, this is so interesting. You've already just told me like so many things that I did not know. It's fantastic. But I also want to talk about cognitive behavioral therapy, because I think that's another thing which, the research shows over and over again that it works. But, it doesn't seem like very many people have access to it or understand what it is. So I'm wondering if you can explain a little bit about CBT and how it works for GI disorders.
Yeah. So the first thing I think to understand is there's general CBT, and you can pretty much find that anywhere. Most therapists are going to be trained in some version of it. The problem comes is that for GI disorders, there's specific protocols that have been developed, and most therapists are not going to be trained in those. And that's where the difficulty comes, because a lot of doctors will, read the research and be doing a really good job and say, oh, this is helpful for IBS.
Yep.
And then they see their patient and they say, oh, you should go out and get some CBT. And the patient's like, can do. And they go in the community and they get their CBT, and it doesn't really help their GI issue. And the reason is it's because that person is probably not trained to specifically work with those protocols.
Right.
So that's one thing to understand. Now, in general, how does CBT work? Well, a key component for a lot of these problems is something called hypervigilance. And that's usually paired with catastrophizing. So in practice, the person's always scanning in an anxious way, scanning their body, looking for issues. And then when they feel something that feels a little off, their brain goes, what the? And just freaks out and thinks of all the worst case things that could happen. Now, if that was the end of it, that would be really uncomfortable and difficult. But a lot of these patients are wired in such a way that stress and anxiety, you don't just feel it up here, it travels down to your gut and starts causing more symptoms. So then you get all these symptoms happening, like an increase in symptoms, and that hypervigilant brain is noticing all of them and catastrophizing even more. So what CBT does is that it brings that process to people's awareness and then gives them tools for changing those mental habits. That habit of hypervigilance, that habit of catastrophizing. CBT is, a big part of CBT is about helping people change the way they think. And those are two examples of habits of mind.
It sounds like CBT would be the technique to go to, for instance, something that a lot of us who live with IBD and IBS recognize is the looking for the next bathroom, and then worried you're not going to be able to find it. And then, of course, then you need to use the bathroom because you're looking for a bathroom.
Yes. Well said. And looking for the bathroom phenomena is an example of that hypervigilance, right? And then as you know, it's probably often paired with that catastrophizing. If I can't find a bathroom, then I just can't go there. And why can't I go there? Because this catastrophic, terrible thing is going to happen. And the other thing people should understand is that when we think catastrophically, our brain doesn't know the difference between our imagination and reality.
Mm-hmm.
So when we imagine having, a terrible accident in public, the brain processes this as if it's real. So it gives you the same level of fear, anxiety, sadness, shame, all those different emotions as if it were actually happening, which obviously for the person is just terrible. But the good news is, again, CBT is about teaching people how to think in new ways that aren't going to work against them, that's going to support what they want in life.
Right. So, but people do need to be aware that there's a specific way to go about it for a GI disorder that's maybe a specialized form of training.
Yeah. So I think over the years, a lot of patients have come to me and I start talking about treatment and what it's going to look like. And I talk about CBT and they, oh, no, I already did CBT.
Yeah.
It didn't help. And I'm like, well, what exactly did you do? Right.
Mm-hmm. Yeah.
Because the CBT you might have been doing maybe was great for anxiety. But the specific types of anxiety and the specific types of problems that people, let's say with IBS face are not the same as somebody with an anxiety disorder.
Mm. Right. So when you're looking for a practitioner, that's something that you need to specifically look for or maybe ask if they've been trained.
Yeah, exactly.
Interesting. Okay. That is very good to know because I did not know it. So even with all of the, the work that I do and speaking to, other healthcare professionals and lots of patients, that distinction has never come up before. So interesting.
Well, that is why I'm here, because the gap between the research and the information people actually have is massive. And I figure somebody's got to get out there and start chipping away at it.
Absolutely. And that's something that I see in a lot of different areas all of the time. We have all these amazing guidelines. I'm so glad that they're there, that how ulcerative colitis should be treated. And then yet I hear from patients all the time that is not, no one is going through the guidelines with them and doing things in that way.
Right. Yeah, I mean, just as an example of that, like it's built into the guidelines for IBS by the American College of Gastroenterology that these types of treatments be used, right? Gut focused CBT, clinical hypnosis. How many people know that?
Or are being referred to the proper professionals for it. So,
right. Yeah.
Oh, again, that's why we're here. But to that end, to be referred, first, you need to be referred to somebody and hopefully it's the right person. But so that's access. And then there's also cost. And I'm thinking in particular of my community, people with IBD. We have a lot of other medical bills. We have a lot of other medical appointments. It's tricky. So do you have any suggestions about ways that people can get mental health care that's more accessible?
Yeah. So stepping back, it's like, okay, there's such a lack of providers. I think at last count, there were like 500 or 600 in the world who are trained in gut-brain therapy.
Wow.
Which is why myself and another psychologist, we started GI psychology, because there just weren't the providers out there. And so I've been in charge of training, and we've got 14 well-trained clinicians at this point, and we can do telehealth all over the country, which is not an easy thing to figure out how to do.
Yes.
We're trying to build that pool of providers up. But what about the costs? Because we're out of network. Well, there's two things I think that can help with that. One is something that I think most people haven't heard of, which is a single case agreement, or in other terms, it's called a gap exception.
Okay.
But long story short, it's basically you ask your insurance, hey, do you have gut brain therapists in network for me?
Mm-hmm.
And the answer is always no, we
Right.
do not. And if they don't, then you apply for this gap exception. And if it's granted, then they reimburse you as if we're in network.
Uh-huh.
And our admin help the patients actually apply for that.
Mm-hmm.
And a very high percentage get it who have private insurance.
Mm-hmm.
They get it. The other thing, so that reduces costs a lot. And a lot of our patients get those. The other thing is something that's kind of exciting that we talked about right before we started, which is the work we've been doing with the Crohn's and Colitis Foundation.
Mm-hmm.
And I know it's been at least over a year we've been working on this, maybe longer. But in conjunction with them, we've created a therapeutic group for IBD patients. So it's a therapeutic group. It's an 8-week program. It integrates cognitive behavioral therapy specifically for GI disorders, and then clinical hypnosis also for IBD. And it's all tailored specifically for IBD patients. Mm-hmm. And we even have one session dealing with the issue of stigma and changing internal stigma. So there you go. And the group format, of course, is a lot less expensive than seeing somebody individually.
Right. Do you imagine patients might think about self-pay for that type of thing, or do you think insurance would cover it?
It does cover it because it is. So there's like kind of two different groups we offer. There's one that's more of a workshop, and that's like a 4-week skills workshop, and that's not covered. But therapeutic groups are covered because it's kind of like it's a therapy, and so insurance will cover it. So that's nice. So it's already cheaper, and it gets reimbursement by insurance. And go ahead. Sorry.
Well, I was just going to say, how is licensing handled? Because I know for myself, if I'm traveling, my therapist is in Connecticut, but if I'm in Florida, we can't have a session. So how does that work?
Right. So, like I said, it takes a lot of administrative hoops to jump through. But so psychologists have something called PsyPact.
Okay.
PsyPact is an interstate license reciprocity agreement.
Okay.
So what that means is like Maryland honors the license you have from like Illinois, let's say, right? And so there's 40 something states for psychologists that have agreed to this. So basically one psychologist could see patients in like 40 something states. So we use that to kind of get broad coverage. And then the states that aren't included, we've gone and gotten individual licenses in those states. So we can say that we're covering all 50 states, which we are.
Wow, that's amazing. So do you have a timeline yet when this is going to be available to people?
Yeah. So we've already started enrolling, like at GI Psychology, we've already started enrolling the very first group. We're already, inviting people to join, and doctors are starting to send their patients. And then on Crohn's and Colitis Foundation end, I think that should be announced within a month or so. And once they announce it, they've got a hotline that they have for patients that if they're calling for financial stuff or they're calling for questions for medications or any number of stuff, they've got this hotline. Right. And then and we're training the hotline personnel about who's a good fit for the group so they can also start recommending it too.
Oh, perfect. Oh, wow. That's amazing. Yeah. This is going to be so helpful to so many patients. I can't get over it. It's just an amazing thing that you're doing. So.
Oh, well, thank you. Yeah, we have one of our clinicians actually also has IBD. And she was generous enough to be our first test subject. Once we, it was myself and another clinician who developed it. And she loved it. She actually had not after, like she was about halfway through and she had a medical procedure she needed to go through. Mm-hmm. And she told us about how she used the skills that she got from the class to like help her with the pain and discomfort for the procedure. I was like, this is perfect. Yeah.
Wow. What a great test subject she was.
Yeah, absolutely.
I'm always amazed when people have IBD and then they also are a healthcare professional in some aspect of IBD, because I mean, it kind of ends up taking over your whole life, I guess. But also to live with one of these diseases that is so challenging at times, but then be able to help others is just really amazing. I'm always in awe of people that can do that.
Yeah, and she's incredibly passionate. Her and another person who works for us, they recently did the Take Steps, mm-hmm. The one in DC. There was one in DC recently. Mm-hmm. I'm sure they have them all over the place. But there was one in DC, and she just loved doing it because, she could connect with all these people that, they all share kind of similar challenges.
Yeah, we almost never meet other people like us out in the wild. So going to those events is really very helpful. Yeah.
Yeah.
Okay. Dr. Navidi, let's finish up by letting everybody know where they can find you, where they can find GI Psychology. And I guess if you have any thoughts about how they can get connected with one of your upcoming groups.
The main website is gipsychology.com. And we offer a free phone consult. And so you just sign up for one of those and they'll tell you about the group and they'll sign you up for it, or and they'll even answer all your questions. We have someone who's clinically trained who will, do those phone calls. Usually it's a graduate student who we've given them a lot of training so they can answer all your questions about treatment and things like that. Mm-hmm. So that's a really easy, free place to start.
Right.
Getting all your questions answered. In terms of social media, I had to look this up special because, I'm not good with the social media. Instagram, I think we're on GI Psych USA. Mm-hmm. So GIPSYCHUSA.
Right.
And then Facebook, it's just GI Psychology.
Right. Perfect. I will put all that information also in the show notes and on my website at aboutibd.com as well, so that people can find it. And Dr. Navidi, thank you so much for speaking with me. This is really incredible. I think what you're doing here is really going to revolutionize the way people see mental health care as it intersects with IBD, and is going to make it available to so many more patients. So thank you so much for what you're doing.
Well, thank you. That means a lot coming from you. And I appreciate it. And it's glad to hear that we're on the right track. And we're going to keep trying to make these services available to people. So thank you.
Hey, super listener. Thanks to Dr. Navidi for taking the time to talk to me about the different types of therapy and how they work for IBD and IBS. You can get links to his practice, GI Psychology, and the small group therapy sessions he developed in the show notes and on my episode 178 page on aboutibd.com. Thanks for listening, and remember, until next time, I want you to know more about IBD. About IBD is a production of Mal and Tal Enterprises. It is written, edited, produced, and directed by me, Amber Tresca. Mix and sound design is by Max Cooney. Theme music is from Cooney Studio.